Hi guys, I am Dr. Alexander Balan and today we will discuss anesthetic considerations in traumatic brain injury. We start with pre-anesthetic evaluation of the patient and we have the following points like determining the degree of preparation of the patient for surgery, evaluation of possible anesthetic difficulties like full stomach, hemorrhage and or hypovolemia, as well as from hemorrhage or dehydration or vomiting at the same time, and difficult intubation. Establishing the anesthetic risk according to the ASA or ASA score, which is American Society of Anesthesiology, elaboration of the anesthesia plan, and administration of any premedication to the patient to secure it. Glasgow Coma Scale, where we're starting with Glasgow Coma Scale, as most of patients coming with traumatic brain injury have altered mental status. And of course, Glasgow Coma Scale is dedicated to the traumatic patients. Here we have three components as eyes opening, verbal response, and motor response. For every of the compartments are given many points, like from 1 to 4 or to 5 or to 6 even. For example, patient coming to the emergency department and have the following, like open eyes to command, talk, and call. 3 points we are giving. Patient is oriented, like we are giving 5 points. And motor response, locate pain stimuli, 5 points. So 5 to 4 and 3. 5 for 9 points and 3 we have 12 points. What it does mean, as we are going to the next slide and see corresponding scale, like 12 points is corresponding with deep obnubilation, like marked drowsiness, difficulty in verbal contact. Every of the summary of points have the corresponding clinical description or mental status. Like 15 points are given for clear consciousness, and 13 to 14 points for mild obnubilation, less 11, 12 for deep obnubilation, 9 to 10 to support or defensive reactions and opening of eyes to pain, some type of description, and less from 8 points is considered coma, like 6 to 8 points coma grade 1, 4 to 5 points deep coma or coma type 2, and 3 points terminal coma with muscle atony and truncated reflexes. Based on Glasgow Coma Scale and high probability of progression of cerebral edema, which is very common to these patients, and if Glasgow Coma Scale is less than 8 points, patient have altered neurological status, central type of neurogenic respiratory disorders or pathological disorders like rapid and shallow. Risk of pulmonary aspiration, so we require by emergency to do or tracheal intubation with rapid sequence of anesthetic induction. Also at this moment we have to administer premedication like anticholinergic, like antisecretory, like prokinetic, and anything else we need. Anesthetics or drugs we have to administer during the induction of anesthesia. As you see here, anesthetics intravenously like cypental, propofol, etomidate. Many of them have side effects, but it doesn't mean we don't have to use them. Ketamine is excluded as this increases cerebral blood flow and blood pressure, which can aggravate extravasation of blood and hematoma. Volatile anesthetics like halosan, isoflurane, sevoflurane, mostly sevoflurane is used worldwide and can produce vasodilatation effect and increasing flux, volume, cerebral, and of course intracranial pressure. Muscle relaxants like succinylcholine increase intracranial pressure and should be avoided. Rocuronium can cause a decrease in oxygen consumption and transiently decrease intracranial pressure because it eliminates thoracic muscle tone and facilitates venous drainage. Atracurium is without effect on intracranial pressure and appears to be preferable. And it is also degraded by Hoffman's reaction in the blood and don't have any serious or active metabolites. Opioid analgesics like fentanyl, sufentanil, cause hypertension resulting in compensatory vasodilation and increased intracranial pressure. Remifentanil is ultra-short, requiring continued use of caution, producing profound cardiovascular depression. A question here is which drug to administer if all of them have a going down-like effect, decreasing in blood pressure or pulse. So in this case, you can assure you by administering through the continuous infusion noradrenaline at low doses for maintaining adequate blood pressure, and of course infusion. Symptoms of increased intracranial pressure that you have to recognize if patients come into the emergency department and you are on call. So nausea or vomiting, pupil diameter changes like anischoria, alteration of the level of consciousness or altered mental status, and Cushing triad, which is very important, like irregular breathing, hypertension, and bradycardia. So to understand clearly, if you see patient with increased blood pressure and bradycardia, low heart rate, irregular breathing, or pathological shallow, you should suspect increased intracranial pressure and start the therapy. Intracranial hypertension, a little bit of theory regarding this. More than 15 milliliters of mercury is considered high or increased cerebral pressure. Symptoms may appear to 18 to 25 milliliters of mercury. Herniation occurs at this level and considered a threshold for initiating hypertensive intracranial pressure to decrease pressure. How about regional cerebral blood flow? So you see here like 50, 80, 15, 10 milliliters per 100 milligram of it's about blood flow through the vessel, 100 milligram of brain tissue per 1 minute. So this level is considered normal, lower considered critical, isoelectric electroencephalogram, and at level of 10 milliliters per 100 milligram brain tissue per minute is considered metabolic failure. The penumbra area has a flow of 15 to 20 milliliter flow, and semi-stable cells that can be saved to full recovery with optimal treatment, including proper anesthetic management. So maintaining of blood flow by infusion and decreasing at the same time intracranial pressure by giving diuretics or albumin. Our cerebral perfusion pressure, which is discussed in many of my lectures, you can watch them previously published. It is represented by net pressure gradient that carries oxygen and not only to the brain tissue, and of course glucose and other components. Glucose is used mostly for brain feed. So measuring cerebral perfusion pressure can be done invasively and non-invasively by measuring mean arterial blood pressure and intracranial pressure. So you see here values that are good and adequate for cerebral perfusion, like mean arterial pressure 50 to 150 and intracranial pressure between 5 and 10. Average perfusion pressure cerebral is generally between 60 to 80. And for example, with mean arterial pressure is 70 and intracranial pressure measured is 10, we will have 60 the perfusion pressure cerebral. And another theory regarding rigid structure of the skull, that is fixed anatomical space, and therefore an increase in three components of the brain will increase intracranial pressure and will decrease compliance. Which components are for this purpose, like vessel or vascular, and cerebrospinal fluid, and of course brain tissue. An increase in blood flow or in cerebrospinal fluid or in a tumor or hematoma can increase intracranial pressure. Normally, cerebral blood flow has the property of self-regulation, and in case of a decreased blood pressure, there will be a dilation of the cerebral arteries and with increasing of cerebral blood flow, and thus maintaining intracranial pressure and cerebral perfusion pressure. Regulation occurs in critical states like intracranial pathology, including shock, hemodynamic distress, and traumatic brain injury. Cerebral perfusion pressure of 50 millimeters of mercury is considered the threshold for the onset of ischemia for most patients, and the lower level of this value should be avoided to avoid complications. Cerebral blood flow and cerebral perfusion pressure will remain constant or considerably unchanged over a wider range of mean arterial pressure. Methods of evaluating cerebral perfusion can be non-invasively and invasively by measuring mean arterial pressure and intracranial pressure. MAP can be measured non-invasively by cuff attaching to the arm or thigh, and invasively by cannulating any of the peripheral artery, and mostly choosing radial or femoral. And of course, this one is invasively to install intraventricular catheter, mostly lateral ventricle. And it can be measured non-invasively by TCD or transcranial ultrasonography by measuring the speed of blood flow in the middle cerebral artery. A self-regulation curve of cerebral blood flow. Very important table that you have to take a look. So auto-regulation is this rectangle, and as you see, many components like mean arterial pressure, like partial pressure of carbon dioxide, partial pressure of oxygen, yes. And let's give us, on the left side, we measuring cerebral blood flow, and here pressure in millimeters of mercury. For example, if patient coming to you and you have on monitor 100 millimeters of mercury of mean arterial pressure, yes, mean arterial pressure, 100. So let's see what is the pressure of PaCO2 or carbon dioxide. Pressure of carbon dioxide should be high, as high level of carbon dioxide produce vasodilation. And what is the level of partial pressure of oxygen is around the same as mean arterial pressure, as you see. If we are going to the left side, we see at high oxygen pressure, we see low cerebral blood flow corresponding to this line. And for vasodilation, we are going to this one, we see increased carbon dioxide level and decreased oxygen. So oxygen is important for vasoconstriction and carbon dioxide for vasodilation. Important anesthetic aspects like prevention of secondary brain injury through the following measures. Preventing of hypoxia by increasing fraction of oxygen, hypercapnia by decreasing carbon dioxide level by increasing heart respiratory rate or increasing tidal volume. Hypotension by maintaining perfusion pressure of the brain and mean arterial pressure, and avoid sudden increase in blood pressure, or also avoidance of hyperglycemia, which is associated with serious consequences like edema, and glycemia under control every hour, and the range should be not greater than 180 milligrams per deciliter or 10 millimoles per liter. So avoiding hypersemia by measuring the temperature of the patient in axial end, which can cause excessive electrical activity of the brain. A correction of anemia by maintenance of hematocrit more than 30 according to practical guidelines in intensive care trauma, and it is recommended to the obvious hemoglobin at least 70 to 90 milligram per deciliter. With brain ischemia more than 90 hemoglobin milligram per deciliter. Multiple studies demonstrate the inefficiency of steroids and on the contrary with risk of gastrointestinal complications and infection, hyperglycemia and adrenal suppression. So do not use steroids in acute phase, especially of traumatic brain injury. Treatment of intracranial hypertension is by raising the head level to 30 degrees, loosen the collar to promote venous drainage or relax it at least. Decreased thoracic pressure at the level of mechanical ventilation by decreasing PEEP or positive end expiratory pressure by 0. Hyperventilation for a short period of time, like 30 minutes, with subsequent decrease in level of carbon dioxide to 30. Sedation analgesia, muscle relaxation or paralysis. Barbiturate coma, it's an interesting term, and should be achieved with 1 or 1.5 milligram per kilogram of thiopental, for example, and then 1 to 3 milligram per kilogram per hour for continuous sedation. Hypothermia or normothermia, mannitol furosemide at the respective doses, hypertonic saline, also monitoring of blood sodium level and osmolarity. If this one is low, the chance of getting edema is high. Surgical decompression with installation of external drainage system of cerebrospinal fluid. It's a way to decrease intracranial pressure, especially draining cerebrospinal fluid. Important is to make antibiotic prophylaxis by broad-spectrum antibiotics, which is initiated immediately. And some of the studies recommend ceftriaxone, metronidazole, and vancomycin for a minimum of 6 weeks for patient with brain injury, traumatic brain injury. And also can be by administration of amoxiclav, comoxiclav, and cefuroxime, and you see the respective doses like 1.2 gram every 8 hours and 1.5 gram, and after 750 milligram every 8 hours. Intravenous metronidazole 500 milligrams every 8 hours. It's about antibiotic administration. Thromboprophylaxis for patients that having an increased risk of multiple thromboembolic events, especially that staying a lot on bedside and have lung and pelvic bones fractures, and being on mechanical ventilation as well is a risk, as patient is motionless. Low molecular weight indirect anticoagulants administered for this prophylaxis, thromboprophylaxis, are administered on the 3rd day after surgery, because earlier administered it can produce spontaneous hemorrhage and aggravate situation. Anticonvulsant prophylaxis with phenytoin, phenobarbital, or carbamazepine can be done. Administration of election solutions, which one are allowed to be administered and which one not. So the normal saline solution or isotonic type could be administered. And avoid, of course, hypertonic solutions that may increase intracranial pressure and cerebral edema. Which one are isotonic? For example, glucose becomes isotonic after the consumption of glucose from that solution, 5% or 10%. And after consumption, this solution becomes hypertonic. And of course, in an acute phase, you should avoid glucose at any of the concentration. Should be avoided at administration. Avoid lactated ringer, as it have 275 millismoles per liter and is considered slightly hypertonic. Albumin have been shown to be increased with increased mortality in traumatic brain injury and also should be avoided. Possible multi-systemic complications like hernias, convulsions, and for this you can administer mannitol or hypertonic saline, or it can be administered by continuous infusion or by automatic syringe, but mostly it is administered in a bolus dose that have immediate response. Mannitol have only after 30 to 40 minutes the real effect. Diagnosis by Ct Mri or for possible brain pathologies like contusion, hematoma, ischemia, hydrocephalus, edema, progressive tumor growth, meningitis, and encephalitis. It can be concomitant or additionally to the acute brain injury. Convulsions, we couple this with benzodiazepines and you see doses like diazepam, midazolam, or with propofol. And after continuous administration for children as well, you see doses. You can take a look at cypental, and the dosage of cypental 2 to 3 grams are considered average, and 10 grams per day maximum. Also for propofol, if you are using for 1-2 days and more, it can produce propofol infusion syndrome. Cardiovascular complications like myocardial dysfunction with ST segment changes like elevation or depression, and hemodynamic instability. Pulmonary system can be with the following like neurogenic pulmonary edema, CID or coagulated intravascular dissemination, hemorrhage, as well diabetes insipidus, which can be treated with desmopressin like 10 to 20 micrograms or 1 to 2 intranasal spray. For children as well, 5 to 10 microgram or 1 intranasal spray. Requires differentiation with nephrogenic diabetes insipidus. As well can occur syndrome of inappropriate antidiuretic hormone secretion and cerebral salt wasting. Thank you very much for your attention. Hope this video will be useful for you and can help you. Bye bye.